Hello and welcome to episode 117 of Chairside Live. We've got a nice episode for you today. We've got part 3 of my interview with Dr. Tarun Agarwal. And T-Bone, as he likes to be called, is going to discuss how much he's seen the evolution of implants since they were first introduced and why they've gotten easier to place and restore. And he's going to share with us that he does in fact love surgical guides for placing implants and that he uses them in nearly 90% of his cases. A man after my own heart. I refuse to place an implant without a surgical guide. I just don't trust myself. And I still think that no matter how good you are at freehanding it, had that same person used a surgical guide, it feels like they would have got maybe a couple degrees better in some direction. So granted, they're still way too expensive, but for CEREC owners like T-Bone, who have the 4.3 software, they can now actually mill their own surgical guides and their own e.max abutments if they want to, and the e.max crown to go on top of it, or a screw retain restoration. So it's pretty amazing. So he's going to share his thoughts with me on that and what he sees the future of implant dentistry going and how it's going to become more consumer friendly as time goes on. But before that, we're going to take a look at our case of the week. And this week, a technician brought this case to me. She's a little frustrated. The dentist is a little frustrated. It's 4 e.max crowns that the dentist tried into the mouth. They fit the model fine, but they did not fit when they went to the patient's mouth. Quick diagnosis, the impression must be wrong if it's going to fit the model, but it's not going to fit in the patient's mouth. So the doctor takes another impression, sends it in. We send back 4 more crowns. And those don't fit, but they do fit on the model. Not the first model, which is the good news. At least the 2 impressions are different, so you get the feeling that the second one might be correct. But it turns out the second one is different and also incorrect because the crowns don't fit in the patient's mouth. And so it's time for a third one, and that's where the technician came to me and said, do you have some advice for the dentist on what to do this third time to hopefully get these crowns to fit? And of course, I did have some advice that I've learned from my own mistakes. So let's go ahead and take a look at the case of the week. This case features 4 e.max crowns that look pretty nice. Hard to tell till they get tried in the mouth if they're going to be great matches. But when they were tried in the mouth, they did not fit. And the dentist set them back and sent them back with a new impression. A second set of crowns were set out that looked very similar to this, and they also did not fit. And the technician came up to me and brought this and the impressions and said, why does it fit here and not in the mouth, both sets, and what's going on? I said, well, let's start with the impressions and go from there. And this is the first impression that was taken and poured up. Obviously, you can see there's still plaster around here. And so when we notice it's 7, 8, 9, and 10, 4 single unit crowns that have been taken with an anterior double arch tray. You can see that little plastic area, that little kind of hook or retainer that sits on the lingual side of the mesh on these anterior double arch trays. I'm not a huge fan of anterior double arch trays just because when the patient bites down, it's impossible to verify whether or not they're all the way together because you can't see the posterior teeth on the other side like you can if you're just doing an impression over in this quadrant. So you need to be real careful and make sure the bite's good. That really wasn't the issue here. The issue was they didn't fit. And first of all, if we go back to Gordon Christensen's research, Gordon has proven that double arch trays like this technique is great if you're doing 1 crown or 2 single adjacent crowns, and that's it. That's the outer limit, are those 2 single adjacent crowns. So whether it's a 3-unit bridge or 4 individual teeth like this is really beyond the indications of the double arch tray technique. And this should have been taken in a full arch, it could be a stock metal tray, could be a plastic tray. The dentist did use a stiff material here. Since these anterior double arch trays really have no reinforcement on the lingual, they're not very strong when you go to bend it in this direction. So at least there's a stiff material in there. But also, when you look and you see that we've only got the light body material right around the teeth and nowhere else in the arch, that's fine if it's a simultaneous technique. So if the green material is expressed around the preps while the assistant fills the tray and then it's put in, the 2 materials set together at the same time, it's usually not a big deal, but you usually see a little more blending at the edges of the 2 materials and you don't kind of see them stop quite like they do. So it gives me the feeling that it might be a two-step impression, because you can also kind of peel a little of the material away. It's been cut down a little bit over here on this side, but it just has that kind of two-step look. Like this was taken first with the blue mousse, so kind of maybe an H&H technique, although I hesitate to call it the H&H technique because it wasn't done with the materials that that technique specifies. But it does appear as though it was done as a two-step, where the blue mousse was done first, the patient opened up, and then some green material was placed around the teeth, patient bites back down. And if you're going to do that, there has to be green material the whole way on the rest of these teeth. All the occlusal surface needs to be covered, because now we've taken an impression where we've got kind of two vertical layers. We've got the green that's here and the blue that was taken previously that was not relined. In fact, in dental school, when we were taking impressions in a two-step method like this, we would take the putty first and then take a watermelon burr and literally just grind out every indication of any tooth that was in there. Basically, we were making a custom tray out of putty that happened to be inside of a metal stock tray, but you had to get rid of every little mark from any tooth that was in there. And then once you had done that, then you could syringe material around all the teeth and put the impression into place. But as it is now, in a two-step technique, as it appears to be, that's going to lead to inaccuracies because we're going to end up with a tighter fit. We're just trying to compress the teeth back into the same blue mousse area and squeeze some of the light body out. And that gets really dicey when it comes time for having crowns fit. And so here's the new impression that the dentist sent back that was fabricated. And you can see on this one, we can still see kind of that where those two layers are going to separate right along here. And that just doesn't happen when these two materials set at exactly the same time. When they set simultaneously, they're much more homogeneous in this area, and you don't see this kind of peel away. So again, it was kind of apparently the same technique. Good retraction, by the way. I mean, that's great. I can see the margins. I can see past the margins in most of the area. Keep in mind that this has already been poured up in stone, so if you see this little tear right here, chances are it could have torn out while the model was being removed. So really a good job on retraction and enough reduction for e.max crowns. It's just this technique that's a little dicey. So first and foremost, it should be a full tray, not a double arch tray, a full maxillary tray, something like a stock metal tray. And if you want to use, two viscosities like this, we would ask that you have them set simultaneously. Again, when we do it in the two-step and we're just simply relining it with the light body, a lot of our H&H doctors will say, oh, can I have 10 coats of dye spacer? Or 8 to 10, is usually what's asked for. And that's pretty thick. That's, all of a sudden we've got, 500 microns of space there, a virtual dye spacer if it's a CAD/CAM restoration, and that's quite a bit. There's that little plastic thing that we saw. In fact, that's another thing. You really can't tell if the patient's biting down on that. It looks like they cleared it, but it looks like they might have started there as they bit together and then cleared it. It was a little difficult to tell, although it looks like they probably were in maximum intercuspation, but it's really much easier to tell if you do a separate bite registration on cases like these. And so that's what I've instructed the doctor to do, and he's willing to give it a try. So the next one's going to be a full upper impression, a full lower impression, and then a bite registration. And we're going to not do this technique. We're going to have them set simultaneously, and hopefully we'll be able to get a better result from that by not taking it in a double arch tray as was done here, and by using a syringe layer around the preparations, and then the assistant fills the tray. It gets sat down on top of that syringed layer around the prep, and it's going to set simultaneously, and 4 minutes later it's going to be one nice homogeneous impression. And considering how well the retraction was done here, I'm 99.9, I was going to say 99.9, I'm 99% sure that these 4 restorations will in fact fit. But you mentioned on the anterior cases that you almost always provisionalize those. Talk a little bit about that, and what percent of the implants that you place do you immediately provisionalize?
Well, our goal, how about this? Our goal on anteriors is 100% immediate provisionalization. I want to provisionalize every anterior implant I place the day I place it. Now, there are times where we can't do it. Primary stability, any number of reasons. Patients bite, you don't want to take that risk. But our goal is to always provisionalize it. And then if we can't provisionalize it the day of surgery, we always provisionalize it at uncovery. And there's several reasons. One, we develop the tissue. We make sure that the margins are correct. If we're going to do a cemented restoration, we don't suddenly have the abutment drawn here and the tissue shrinks or goes high, and now we have a deep margin that we can't clean the cement, or now we have a margin where the zirconia or the titanium is showing through. So there's a lot of value in provisionalizing. We're even doing techniques where we're provisionalizing in advance, where we're able to, using guided surgery, fabricate our provisional in advance so that it's ready the day of surgery.
And how about posterior teeth?
Posterior teeth, we're not provisionalizing those. We're waiting for them to heal. In fact, in the beginning, I was doing single-stage surgery where I was putting healing abutments on. I got tired of those circular healing abutments like we talked about earlier. So now I'm bearing all my posterior implants. And what we're moving towards is this concept of one abutment, one time. And what we're trying to do is the day we uncover the implant, I want to load the restoration. So that way we don't tear the tissue attachment, we preserve the most amount of bone around it, and we minimize the patient visits. And then when we can't do that, I'm almost always using a custom healing abutment in the posterior.
Okay. So what do you I think I know what you're going to say, but what do you think are the most significant, let's say the most significant technology centered around this type of implant dentistry, and the most significant maybe material, so a non-technology kind of thing that you use that really helps you?
It's a good question. I would say without question the technology is going to be cone beam.
Right.
Okay, it's the driving force. It's X-ray vision. I look at a patient, I say I can do this, I can't do it. Or I look at the patient, I can say you need to do this. This is going to be pretty straightforward. You're going to need a couple of ibuprofen and that's it. And they look at you amazed. So that's the driving force. Secondary to that is going to be digital impressioning. We haven't taken an implant impression with polyvinyl impression or alginate or polyether or whatever else. I don't know how long. Everything's digital. Back to and then the material. I'm a believer that titanium's titanium. I think the big difference to me is in the implant design, the thread design, the ability to do a minimal preparation, have the implant expand and condense the bone, be able to get a bigger implant in a thinner spot, be able to create stability, primary stability, to be able to load the implant. I think the big technology is not on the surface treatment. Right. That's what's going to save me a few weeks, a few months. It's not worth the hundreds of dollars for that. Right. I think the big push on the technology on the implant side is going to be the thread design, the thread pitch, the beveling of the neck, the connection, some of the treatments they do around the collar of the implant. I think those are the bigger movements forward.
And those things are all related to mechanical retention versus a chemical retention that's around there. And it's not unlike us doing an amalgam or anything else where we need retention on that restoration or a crown. If we have a crown that's the prep's a millimeter tall and it's tapered at 40 degrees, there's no cement in the world that's going to hold that on and
long
keep that
term
in
at
place.
least, right? Yeah.
How many surgical guides are you using these days when you place implants?
90% of my cases.
Really? Still doing 90%? That's fantastic.
It's what we separate our practice as. And every time I try to do an implant without a surgical guide, it's just off a little bit. And that's all it takes when you go to restore it.
Right.
And you're like, man.
You mean just a couple degrees off axis where it should be? Or
more like 10, 15.
Okay.
My ego says I'm perfect, okay?
Right.
But I'm not, okay? It just takes it off a little bit. And so I would say 95% of our cases are using a surgical guide.
And I've always think of it this way, like I know most specialists don't use a surgical guide when they place them. They say, I've been doing this for 20 years. But anytime I get on an airplane to fly somewhere and speak, there's pilots sitting up in the front who've been doing this for 20 years. And they still pull out a checklist because they don't want to crash and kill 200 people behind them. So they take out their checklist and go down it. And that's how I think of the surgical guide. So to hear you, I'm impressed that you're still doing it on 90% because, yeah, you could probably get most of those in without a guide and get them close. But why not get it exactly right where the plan is?
Listen, it creates everything after that. The restoration's easier, it's better, it's more comfortable for the patient. It's all those things. And truthfully, if we were to be honest with ourselves, the only reason ego is one of the reasons somebody won't use a guide, okay? Mm-hmm. But the only real reason that somebody doesn't use a guide 90, 100% of the time is cost.
It's gotta be money.
It's gotta be money. Dude, there's enough margin in this stuff. Are you kidding me? At 30, I don't like to share too much stuff, but for me to plan, place, and restore an implant is $600. Using a name brand implant that costs $350, $400.
And the surgical guides included in that
guide as well. And the restoration. So
Right.
To save $150? Are you
Right.
kidding me? For that peace of mind, for that experience.
And you just get to go faster because you know where you're going.
And I don't worry about it.
Right.
I don't spend 1 minute worrying about it. We just do it. My team looks at me like, why are you doing this without a guide?
Right.
It's just not worth it.
We worked with surgical guides here at the lab, but it got to a point where they were so expensive that it really didn't represent the kind of value brand that Glidewell is, because that's really what we are.
Not yet.
You can get crowns for $39, offshore and even here in Southern California, and you can get crowns for a heck of a lot more.
Yeah.
But at $99, and so there's people charging $650 a crown, like Matt Roberts, where it's just unbelievable
gorgeous.
work. It's gorgeous.
Yeah.
It's insanely gorgeous. But at $99, it's hard to beat us. It's hard to find a better $99 crown than ours.
They can't compete.
Yeah, there's better crowns than ours and worse, but it's just hard at $99. And the surgical guide cost so much that it didn't really fit in with that. And so we kind of quietly, and Dennis kind of didn't want to buy something that expensive from us either. So we kind of took it off the shelf and waiting to come out with one of our own that's going to be value priced. And hopefully we're going to see Dennis really embrace this and not just use it for their first 10 cases, but use it on everyone. Why not get this right?
You get hooked. And I think when we get guides in the $150, $200 ballpark, I think we'll start seeing a bigger movement towards it.
Right.
I think when we see implants being packaged with the guide, so you don't have to worry about inventory.
Right.
When we start seeing drills packaged with it, sounds familiar, doesn't it?
Yes, it does. And I don't know if you think this is a good analogy or not, but I always think about what if you had an endodontist who goes, I've been this 20 years. I can feel the apex with the file. I don't need an x-ray. I mean, it's kind of, is that the same as a guy freehanding an implant? I don't know if it's that extreme, but.
Yeah, but it's back to the endo analogy we made. How many of us would stop using our apex locator?
Well, that might be a more appropriate
So why would I
analogy.
stop using the surgical guide? Listen, all it takes is one nerve, and you're done. I mean, it's not worth it.
Right.
It's really not worth it.
Why not get it right? I mean, it just seems really easy. So what % of your cases are you restoring chairside? And those that you are restoring chairside, what's your material of choice, or what's kind of the breakdown of materials that you use?
Well, I would say of our single units, posterior single units, I'm restoring 95% of them chairside. Of my anterior units, I'm restoring probably 60% of them chairside. I would say my number one material of choice today is lithium disilicate. My number two material of choice is going to be Bruxzir solid zirconia. And I would go further and say that 90% of my restorations are screw retained. In fact, I go through pains when we're designing the implant virtually to plan it so that I could do a screw retained restoration.
Really? And what influenced? There must have been something that has influenced this decision that got you to that point.
Yeah, the first time you have an implant fail and your periodontist or you uncover the implant and there's just cement everywhere.
Right.
That's all it takes. If in fact, I'm not a literature guy, so I can't quote the literature, but I can tell you that the two most common reasons for implant failure post-integration is going to be heavy occlusion and cement left behind. And so I take the cement out of the equation.
Let me ask you this. Do you feel that you and your staff leave a lot of cement around crowns that you place on regular teeth, crowns on teeth?
Well, that's how we've improved. That's why our perio numbers are so good.
Right.
When my practice went through a lull, I said, we got to improve our, consult. Of course, the consultant comes in and says, your perio numbers are low. I said, I got a solution for that.
But why is it so?
I'll leave cement.
That's a good idea. There. Plant some perio seeds.
Yeah, exactly.
Why is it so difficult to remove the cement from around that implant completely as compared to a crown, that same restoration on a tooth, for example?
A couple of different reasons. One is when you have a custom abutment, any abutment, and the implant, the restoration made to it fits so good, you have so much cement expressed out. Right. Okay, because what are we taught? We're taught to load that thing up, fill it in, and then press it down, and then we just have so much cement. Two, a lot of these times we're placing the restoration not numb. Mm-hmm. So how many of your patients want you digging around there? I think the other reason is too many people are using stock abutments. Mm-hmm. And what happens with a stock abutment? It's a circle, the margin's at the same level, it's fine in the buccal and fine on the lingual, but where is it in approximately? It's 4 millimeters subgingival. You can't clean it. My hygiene, you can't clean it 4 millimeters subgingival.
Right now without a scalpel.
No, or without getting them numb and getting one of those fancy hygiene instruments that my hygienist wants all the time.
Any disadvantages to screw retained, or what?
I haven't seen any. I know people tell me, well, the literature says this and that, and I go, well, those were UCLA, those were feldspathic on top of metal. That's a totally different ballgame than monolithic implant restorations. Mm-hmm. The other key to this, though, is when we do screw retain, it's not a solid lithium lithium disilicate or solid zirconia, the connection to the implant is in titanium. And that's important. So let's call it a hybrid kind of case. We have a titanium base where you put everything on top of it, and the connection is still titanium. We haven't seen any. In fact, I've seen only advantages. Things like, I know the manufacturers love to say that screws never loosen. But I don't find that to be the case. I would say that 99% of the time that's true. Well, all it takes is one, right? Number two, like I have a patient coming in missing 19 and 30. I'm an implant practice. Patient says, hey, we'll do 19 this year, 30 next year. I can make my guide for both. When I place this implant, restore it. When I go to place this implant, I just unscrew my restoration. My guide fits in, put the restoration back in. Go and put a patient in, they're having some trouble with it, something's not right, the occlusion needs to be fixed. Just unscrew it, fix it, reglaze it, whatever I need to do. There are a lot of advantages to going screw retained.
You know, it's funny because all those things you just mentioned, you start to think, wow, that'd be really awesome to be able to do that on natural teeth too.
Yeah, we just pop those out, pop them back in.
Exactly, take it back out, put it back in, clean it out, do whatever needs to be done.
Just do the endo that way, do the apico.
Exactly. So you said that on the anterior teeth that is it about 40% or 50% you said you do?
50, yeah.
Is it based on how demanding the patient is aesthetically and what you're trying to match, that kind of thing?
It's based on a couple of different things. One, it's first and foremost based on the aesthetic demands of a patient. If I were seeing you, I would tell you that a lab's going to do it. Right. Okay. If I were working on the Vita Shade Guide, I can tell you I'm going to do it. The second thing that comes into place is the difficulty of the abutment. As a chairside owner, I can do my own abutments, but there's some limitations. There's some times where there's just an art where you need somebody that's experienced in designing that abutment because it supports the restoration, it supports the tissue. So if there's some difficulty, if the implant was placed in a not ideal position for whatever reason, then I return to my team partner, the laboratory, to take care of that.
So what percent of these restorations that you're doing in office this way would you say you're doing modelless versus having some sort of model as you're working on it? I know that you never need a model for any of your regular CEREC dentistry, of course, but
let's break cases down into simple implant cases, 1 to 3 teeth, okay, and then everything beyond that, okay. 1 to 3 teeth, I would say that 99% of our cases are modelless. Right. Okay. In fact, I started doing my first digital implant restorations with you guys here at the lab, and I called the lab and said, hey, how do you guys, because I know they were all being done CAD CAM, and they said we take a scan post, we scan it with your desktop scanner. I said, can I just scan it in the mouth? They said, we don't know. Let's find out. So we scanned it in the mouth, and sure enough, why even have a model? Think about what that saves from a lab end. And then the beauty of Glidewell is you pass it on to me.
Right.
Model, soft tissue model. You look at your implant bill. It's unbelievable. There's the model, the soft tissue model, the restoration, the little jig. It's just like the little parts and pieces everywhere.
And you've got now a model that you're pouring up. There's not, we have these batch mixers, so we're getting the mixture of powder and stone exactly right, but it's still not perfect. Yeah, it can still mess up and not be there. There's so many good things. And we decided, to give the $20 off because we didn't think $3,500 that you were charging was enough. We thought you were about $20 low.
Exactly.
But it was really kind of a thing where selfishly on our part, it was kind of a competitive advantage to get a foot in the door. But when we added it all up and looked at it, we're like, hey, the dentist is doing something in our benefit and his benefit and the patient's, but he's saving us all these steps. It seems like the right thing to do to pass this on.
But it's not even the stone, Mike. The stone's one part of it. A lot of the mistakes come in when you put the impression coping back in the impression.
Right.
All you got to do is have it turned off a little bit. Have you ever gotten an implant restoration, you put it in, it's kind of like it's cockeyed a little sideways? And that's usually from not necessarily a bad impression, but a bad putting the impression coping back into the impression. So, there are a lot of benefits of being digital. A lot of benefits. Listen, that's what I love about the lab. I mean, I remember when we first did our first digital impression, I called the lab up and I said, hey, this is great. It worked fantastic. Here's the problem. I can't take a verification x-ray. It doesn't show up. They said, give us a week. So then a week later, they sent me a new impression post with barium sulfate in it. So now I can put my digital impression coping in there, take an x-ray, and voila, it shows up. So again, the technology doesn't take away the fundamental concepts. We still have to have verification x-rays. We still have to have all these things to make sure everything goes well. And the other beauty of it is how fast do I get these back? We talk about teeth moving with temporaries, and that has some contact at least. Now we're talking about an empty space. Right. 3 weeks, what's going to happen to those teeth? They're going to move. how much are they going to move? So in that time when you took that impression and 3 weeks later when you go to deliver it, I bet a lot of people, if they were truthful with themselves, would realize that they're adjusting their implant restorations a lot.
Right.
Yeah.
Well, it sounds like you're taking advantage of almost all the technology, if not all the technology that's currently available for this type of dentistry. What do you see on the horizon what do you see as coming next, or some of the more promising technologies that might make this even easier or quicker or easier for the patient to heal? Or
Well, a lot of things. The first thing I see that really has me excited is full arch implants. These hybrids, zirconia hybrids, the ability to mill solid zirconia onto 4 or 5 implants to replace a full arch, the ability to get that digital, the ability to get that down in 2 to 3 visits where we can control the bite, control the occlusion, control the aesthetics. I'm really excited about that, and we're doing some great work with the lab on their solid zirconia hybrids, which are looking pretty darn good. The other thing, I'm looking forward to the time where we have a little bit faster integration, where we can really place that implant and get it integrated within a month, to where I can take my digital impression the day I place the implant and the patient walks in and I've already got it all made for them, ready to go. I would like to see us move towards custom implants. You know, imagine a day where I take a CT scan of your head, I know exactly where your molar is, I know exact shape of it. Imagine being able to mill a zirconia implant with the prep already on it, take your tooth out, pop this thing in, ready to go. I would like to see some of these things come to fruition. I'd like to see implants become more affordable for the mainstream without affecting our profitability. Okay, and I think that's where we start seeing a real movement towards this becoming big for our practices.
And becoming kind of the de facto treatment for missing teeth. You know, I mentioned to you earlier that we're really pleased at the lab to see the number of 3-unit bridges that we do continue to come down year by year by year by year. And the only way that happens is by watching the growth of our implant department at the same time. And we both know that if you're going to take a missing lower first molar, and the second molar has an MO amalgam, and the second bicuspid has a DO amalgam, and you're going to prep that all the way down, I think you and I at least would both consider that to be malpractice, even though I think at the standard of care, you'd be okay. It'd just be another alternative way to do it. But it's nice to see that it's getting closer and closer to kind of being a default treatment choice. And it's going to take more dentists. You know, you're just one dentist in North Carolina. There needs to be 50, 60, 70,000 dentists across the country who feel that comfortable with the technology, where it's going to become their go-to diagnosis for a missing tooth.
Well, what I tell people, I make bold statements. Sometimes I mean, it's the emphaticness. I say bridges are dead. I can't count. We haven't done one bridge in our practice this year, not one. And I refuse. Patient says they have. We talked earlier. If they have a crown here and a crown here already, I still tell the patient no. You know, and if it comes down, well, it's cheap. I'll just do it for that fee. I don't care. Okay, because I so believe that bridges fail. And I'm not convinced. I think they fail because you put bridges on them. You know, and I always tell people, what would you do in your own mouth? And why should we treat our patients any differently? And the excuse that I hate the most is money. Okay, I hate it when they say, well, the patient couldn't afford it. I go, then take care of it for them. You know, people do these large fillings. Oh, the patient couldn't afford it. Just pull out your CEREC machine and do one. Who cares? Just do the right thing. And it's just I don't want to go there.
Right, exactly. But I know what you're saying. Well, that was fantastic. Thanks so
Mike.
much for
Appreciate
dropping
it.
by.
Yeah,
Appreciate you
absolutely.
sharing your knowledge, experience, and actually being so forthcoming about your fees. You know, fees are, nobody ever wants to talk about them, but it's really good because that idea of the flat fee, I think, is going to make it a lot easier. You've seen what we've tried to do at the lab. We try to do flat fees for implants
That's where
too.
I got the idea from.
Yeah, because it's such a crazy thing, and dentists hate that kind of uncertainty. Dentistry is hard enough, especially if you're losing money on it. So thank you for being so honest and sharing all that stuff with us.
It was a pleasure.
T-Bone's one of the most down-to-earth guys that you'll ever have the chance to meet and learn from. Really, everything is done at such a basic level, so he assumes no prior knowledge and works his way up. And really, his area of specialty is the integration of, in this case, the cone beam information that he gets from his Galileos and merging that with the CEREC and this whole new three-dimensional dentistry that he is able to do. And so if you're interested in learning more about this, he's got a teaching facility in North Carolina, and you can go to 3d-dentist.com, 3d-dentist.com to get more information on that. It is really good stuff. So on behalf of myself, the whole CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.